Welcome, everyone. Thank you for joining us today for this live Google Hangout from Evidence-Based Mental Health. Welcome, everyone, for this Evidence-Based Mental Health Google Hangout. Today we'll be discussing a paper that we recently published called Pharmacological and Non-Pharmacological Treatment of Adults with ADHD. Delighted today to be joined by three of the authors of that paper. With a couple of additional guests. I'm Michael Ostacher, Associate Professor of Psychiatry at Stanford University and the Digital Content Editor for Evidence-Based Mental Health. We're joined by Franco di Crescenzo, who's a psychiatry trainee at Catholic University in Rome, and on a clinical and research attachment in Oxford. He has a Master's of Science in Clinical Pharmacology. Samuele Cortese is Associate Professor and Consultant Child and Adolescent Psychiatrist at the University of Southampton in the UK, and also a member of the European ADHD Guidelines Group. Nicoletta Adamo is a PhD student at the University of Psychology and Neuroscience at King's College in London in the UK, and a Consultant Child and Adolescent Psychiatrist at the Michael Rudder Centre at the Maudsley Hospital in London. We're also joined by two discussants, Steve Ferrone, who's Distinguished Professor of Psychiatry and Neuroscience and Physiology at SUNY Upstate Medical University in New York, joining us from the United States, and Sandra Kooij, who's a psychiatrist at PsyQ in the Netherlands and Associate Professor at Free University in Amsterdam. Why don't we get started with a presentation? I think we have a presentation of the slides, and we can get into a discussion. I think it'll be a quite lively discussion this morning. We'll focus both on the pharmacological and non-pharmacological treatments of ADHD. Franco, you're welcome to begin.
Thank you very much, Michael, for the presentation and for inviting me as well, of course. So this is a paper we wrote, first of all, to review recent developments on pharmacological non-pharmacological treatment of ADHD in adults. And it was written with my colleagues, as we mentioned before, Samuele Cortese, Nicoletta Adamo, and Luigi Ianieri as well. We are an interesting mix, I have to say, of child, adolescent, and adult psychiatrists, which I think is quite important for a topic like this, where in child and adolescent we have a lot of evidence, really, while in adults the evidence is in the process of being built, although much has been done already, of course, we have to say. We have some way to go still. What we did so is a so-called meta-review, which I briefly explain, is a review of the literature, basically focusing on recent systematic reviews and meta-analysis, obviously on the treatment of adults with ADHD. And we have to say that there is really a lot of primary and secondary research published in this topic, really recently, we have to say. And it's not easy, I think, for clinicians to appraise all this research. So really, the aim of our paper was to help clinicians to make an evidence-based decision, to help them taking them in their daily practice. And what we found, in fact, was an impressive number, I have to say, of 40 studies among systematic reviews and meta-analysis published in the last few years only on the treatment of ADHD in adults. And what we try to do is to answer 5 important clinical questions, 5 questions that we thought were particularly important clinically to address the matter, and which were basically about the efficacy and acceptability of pharmacological and non-pharmacological treatments, on multimodal treatment, which is quite a topic in children and adolescents, while in adults we don't have much evidence still, and also what we should do in case of a co-occurrence of substance misuse and ADHD. I'd like now, I think, to give you a little bit of a background on very shortly on what it is ADHD in adults for people that might not be entirely familiar with that, and then I would like to let Samuele and Nicoletta take over to talk a bit more about the findings of our papers. So I will try to share with you my slides, if I can. Yeah, please let me know if you can see them. Can you?
Yes, perfect, very good.
All right. So this is basically the title of the paper. So basically, ADHD is a common syndrome. It's a common disorder with a prevalence of 5% in children and 2.5% in adults, roughly. It requires for the diagnosis symptoms of inattention and hyperactivity or impulsivity. Symptoms need to be present in more than one setting, normally. Academic, social, occupational settings, at home, and they have to lead to a functional impairment. Based on the current diagnostic criteria, we have to say ADHD onset is by definition in childhood. But we have to say that there are quite a few papers that have been published recently suggesting that ADHD could have an onset in adulthood as well. I'm referring to the Moffitt paper, Kooij, and I mean, quite a few papers recently, really, about that. But we have to say that this evidence also has not yet been extensively reviewed, let's say, and quantitatively assessed in current guidelines. So we can't yet say that, I mean, so the onset that we have to refer is still in childhood, and also clinically, we should probably try to see whether the onset, try to ascertain an onset in childhood. For the diagnosis, we use also a diagnosis structured interview in adults, which is the DIVA, which is based on DSM-4 criteria. So which are the differences between diagnostic criteria? Because there are quite a few, I think, and this is quite important. So the ICD-10 requires the presence of symptoms for hyperactivity, impulsivity, and inattention as well. So, and it requires for quite more symptoms than the DSM-5 and DSM-4. So it is, we could say, more what in DSM-5 and 4 is said to be a combined presentation of ADHD and a severe form of ADHD, rather. The age of onset for the ICD-10 and DSM-4 should be before 7, while for the DSM-5 has been raised to 12 years. But actually, as we mentioned, I mean, DSM-5 was released in 2013. Since then, there have been a lot of papers saying that ADHD onset might be in adulthood as well. But this hasn't been reviewed extensively, as I mentioned before. Comorbidity, DSM-5 allows the diagnosis in comorbidity with autism spectrum disorders. ICD-10 instead doesn't allow the comorbidity with autism and also with affective disorders and anxiety. Settings, DSM-4, the DSM-4, DSM-5 respect DSM-4 strengthens the cross-situational requirement to several symptoms in each setting. Before it was one or more. Now it is 2 or more settings, including, as I mentioned before, educational settings, occupational, social, at home. Subtypes, the ICD-10 definition, actually the ICD-10 doesn't speak about ADHD, but it refers to rather HKD, which is hyperkinetic disorder, and it overlaps with a combined and severe ADHD subtype that is recognized for DSM-4 and combined and DSM-5 as well. So now I think it would be most useful, I think, if Samuele and Nicoletta could you go through the findings of our paper about specifying pharmacological and non-pharmacological interventions.
Yes, thanks, Franco. I will start with the pharmacological intervention. So I will try to share my screen. Can you see my slides?
Yeah.
Yes.
Yeah, great. So as Franco mentioned, we built on the 40 systematic reviews and meta-analysis that we found to address clinically relevant questions. The first one being around the efficacy of pharmacological treatments of ADHD in adults. So all systematic reviews and meta-analysis that we found showed that the most commonly used medications for ADHD in adults compared to placebo are more efficacious, at least in the short term, with different effect size though. In particular, in terms of methylphenidate, both immediate release and sustained release, the average effect size found was around 0.55, which is somewhat lower than the typical effect size found in children. Amphetamines had a large effect size. In particular, lisdexamfetamine had the highest effect size, around 0.95, and this is quite consistent with findings in children. Similarly to studies in children, atomoxetine, a non-psychostimulant, had a moderate effect size, around 0.47, which is then lower in general than the effect size of psychostimulants. We didn't find enough evidence for other medications such as bupropion, buspirone, so we did not include them in our review. So the second question was around the acceptability, which is defined as the number of subjects who drop out from the trial due to any cause, and the tolerability, which is reflected in the number of subjects who drop out because of adverse events during the trial. So based on the systematic reviews and meta-analysis of randomized controlled trials that we found, we saw that compared to placebo, psychostimulants were equally acceptable but generally less well tolerated. In particular, Oros methylphenidate was less well accepted, and dexamphetamine and lisdexamfetamine were equally acceptable, and indeed mixed amphetamine salts were generally more acceptable, so less subjects tend to drop out compared to placebo. And considering all amphetamines, in general, they are less tolerable. In terms of side effects, the most commonly reported ones were a decreased appetite and an initial insomnia. This is consistent with evidence in children, but it's important, I think, to stress that these are usually temporary adverse events, and this came from a short trial. There was also an increase, general and average increase in heart rate and blood pressure, but as you can see from the slides, the values are quite modest, with a mean of 5.7 BPM and 2 millimeters of mercury. Importantly, there was evidence of low rates of hypertension and tachycardia and other severe cardiovascular events in the reviewed studies. Moving to the acceptability and tolerability of atomoxetine, in general, it was less acceptable compared to placebo, with more sexual and genitourinary side effects. But importantly, there was no evidence of an increased suicidality. So to sum up, the acceptability and tolerability of all pharmacological treatments for ADHD, it can be stated that in general they are less accepted and tolerated than placebo, of course, with an adherence which, however, goes from 52 to 87% on average. And compared to children, there is a tendency to a higher discontinuation rate in the longer term in adults than in children. Now, the last questions we had in terms of pharmacological treatments, we think is a highly relevant question for the clinical practice, namely how several compounds compare each other and rank in terms of acceptability, tolerability, and efficacy. And this is clearly important to guide daily decision-making. However, we could not address this question because of the limited number of head-to-head trials. Individual studies shows that effect sizes for amphetamine seems to be higher than for methylphenidate and atomoxetine, but this question needs to be better addressed. And the way to address this is to use a meta-analytic technique, which is referred to as network meta-analysis, which allow the comparison of different medications, even if they have not been compared in head-to-head trials directly. And to our knowledge, there is no published comprehensive network meta-analysis of all ADHD medications in adults. However, we are conducting this meta-analysis both in children and adults with colleagues of the European Alliance Group. You can see here the first page of the protocol that we published recently. And hopefully, at the end of the year, we hope we will be available to present the results of this network. Is a quite large project, and we hope that this will inform the clinical practice for clinicians. And that's more or less the summary for the pharmacological results. Now I will ask Nicoletta to go on with the non-pharmacological treatments.
Sam, can I interrupt you?
Sure.
Just a minute about the pharmacological. One important to point out that in some of the methylphenidate studies of adults, the doses were fairly low.
Right.
And I think that's why you got that lower effect size in adults.
That's an interesting question. That's an interesting question, and we were surprised as well. This came mainly from a Cochrane meta-analysis by Castell and our colleagues. And I suspect that the criteria inclusion of the meta-analysis may have played a role in this effect size, which is actually lower than the typical effect size that we find in children, around 0.7, 0.8. This has to do with the inclusion criteria of that particular meta-analysis.
Yeah, when Jan Budlar and I published a meta-analysis of amphetamine versus methylphenidate, we found a small advantage for amphetamine, but not as large as what's suggested by what you had presented. I think it has to do with, obviously, with inclusion criteria and so forth.
Mm-hmm. Yeah, so for that, I'm with myself, yeah. So for the last few questions, I'll share my screen. Hopefully you can see it now. Yep.
Yep.
That's great. Oh, I see it blank.
Yeah, we can see it, Nicoletta.
Can you see it now? Okay, yeah, that's great.
Make it,
so one of the last few questions we tried to answer with our meta review was what was the evidence base for the efficacy of non-pharmacological treatments in adults with ADHD. So clearly that is an important question for clinicians because although guidelines, at least in Europe, for example, the NICE guidelines do indicate pharmacological treatment as a first-line treatment for adults with ADHD, the second line of non-pharmacological interventions are still quite important, both in cases where pharmacological treatment is not sufficient to control the core ADHD symptoms, but also for those individuals who have a strong preference for a non-pharmacological intervention. So overall, when looking at the summary of evidence available at the moment, we found that there are preliminary positive results for non-pharmacological treatments such as mindfulness, dialectic behavioral therapy, cognitive behavioral therapy, and that also some of these behavioral interventions can have a positive effect on secondary outcomes, such as, for example, driving performance, which is quite an important outcome to consider in daily functioning. However, the evidence that we found was mixed and somewhat inconclusive, especially because not all these trials that were pulled in this analysis they were not necessarily randomized or coming from randomized trials, and also they might depend on the rater. So, for example, self-rated measures were indicating more positive results, while those significant effects were not seen when the clinician would rate the outcomes. In terms of combining the treatments, the pharmacological and non-pharmacological treatment, we couldn't find any systematic reviews or meta-analysis that summarize the evidence on multimodal treatment, so when combining pharmacological and non-pharmacological interventions. And that was, so we could only find a few individual studies, and those two studies basically showed contradicting results. I'll go briefly through the last point, and then we can also discuss more. I'm sure there will be questions on these two points we addressed. So when we looked at the evidence of the benefits of ADHD medications on the co-occurrence between ADHD and substance abuse disorders, we found that the evidence was showing that ADHD pharmacological treatments had positive, were beneficial in treating the ADHD core symptoms, but not when the outcome was drug abstinence for the substance abuse disorders. Quite reassuring finding was that there was no evidence for serious side effects in the concomitant treatment with pharmacological treatments for ADHD and alcohol or recreational drugs. Although we were a bit wary, and we need to treat this finding with caution, because these findings were based on relatively few studies and also mixed evidence from animal studies. Of course, we needed to take in account that, so we did find that there was evidence for a rate of misuse of prescription of stimulants that was quite high, of up to 70% in college students with ADHD. And that kind of told us that the treatment for adult ADHD adult individuals with ADHD that require treatment for the ADHD symptoms need to be treated with a crafted package of care in secondary care mostly, and possibly in collaboration with professionals experts in substance abuse disorders. So I guess that's it in terms of the findings, but probably one point, I'll stop sharing my screen, probably would be good to discuss, first of all, what we found in terms of the non-pharmacological treatments. I guess that one lesson we learned in child and adolescent psychiatry when non-pharmacological interventions were looked at was that there could have been a rater bias. So the findings could have been determined, could be very different whether all the criteria we usually look at when investigating evidence-based for interventions are, they're quite important. So the blindness, for example, was quite an important factor. So when taking in account that raters could have been not fully blinded, those positive effects of non-pharmacological treatments in child and adolescents with ADHD were not significant anymore. So maybe Samuele can comment on this more. He's been quite involved in those studies, and I'm sure he will have.
Yeah, that's correct. We, as a European ADHD Guidelines Group, we published a series of meta-analyses in the past 4 years on non-pharmacological treatments for ADHD, basically including parent training, behavioral treatments, diet interventions, cognitive training, and neurofeedback. And as Nicoletta was highlighting, the key message was that when we considered ratings of ADHD core symptoms by individuals who were likely blinded to the allocation of the treatment, none of these treatments, with the possible exception of free fatty acid diet, were efficacious to significantly reduce the core ADHD symptoms. I thought they may be efficacious to reduce other components, domains associated with ADHD, such as oppositional behavior, for example, for parent training. But the key point highlighted by Nicoletta is an important one, and we need to look better at the type of raters, and this has not been done systematically in adult literature.
For those who have joined us for other Hangouts, this typically is part of what we end up discussing, which is the methodologic issues that are involved, especially biases like this, where if you're doing a non-pharmacologic intervention, you're doing a psychotherapeutic intervention, the importance of blinding to treatment assignment is typically extremely important in terms of understanding whether or not the effect can be one that is trusted. I want to remind our viewers, listeners, that if you have questions, you're welcome to tweet them to us at our hashtag EBMHchat, EBMHCHAT. I think it's reasonable to go into a discussion right now. We can continue, since we've just ended on the non-pharmacologic treatments, to talk about this. I don't know if anybody has any comments before we return to the pharmacologic treatments about how one might make recommendations in adult ADHD for pharmacologic treatments, I mean non-pharmacologic treatments, given where we are with the data right now, and whether or not it's more important to continue to study the question going forward.
Yeah, this is Steve Ferrone. Let me add to Sam's comments that in addition to the problem with the blinding, where significant effects have been seen for non-pharmacologic treatments, they tend to have small effect sizes when given without supplemental medication. And in adult ADHD, the best findings, for example, probably the best findings for cognitive behavior therapy, where there are a number of studies showing positive findings, but that is typically in a sample of people who are treated with stimulants. And the question is, does CBT enhance the effects of stimulant treatment?
In other words, synergistic effects, Steve. In other words, is there an additive effect, or even a more than additive effect?
Yeah, there seems to be an additive effect, and it's not clear that people will benefit from CBT if their ADHD is not already under some control by medication.
Yes. Yes, I think it's important that we study what the additive effect might be when we treat people with medication and CBT, which we do on a regular basis here in Holland, because people want more than pills. They need more than pills alone. They need training of skills. They need education. They need support and structure. And we have the opportunity here to measure routine outcome measurements that are sent by email to all patients after every 3 months. So we hope in the future to be able to deliver some data on what the effect size is using the ADHD rating scale for the combined treatment that people get here.
So why don't we go back to what I think is central to this, which is the diagnosis of ADHD in adults itself. I know there are a lot of studies that you included in your meta-analysis. Is there a consistency to how the diagnosis is made across them, or is there some variation in how the diagnosis is made?
Well, there is a bit of variation in the sense that the studies come from different years, of course, and so they might have, I don't know, DSM-4 rather than DSM-5, for example. It's quite recent, so we don't have many studies referring to the DSM-5 as a diagnostic criteria, which are slightly different, but not massively different with respect to the DSM-4 ones. Or we might expect a little bit of a an increase of the diagnosis of ADHD with DSM-5 criteria, but not really that much. I think that it's quite important also. I mean, after the DSM-5 has been released, which was 2013, I think there have been a lot of studies, observational and prospective studies, about the fact that actually the diagnosis of ADHD could be made also in adulthood, regardless whether the adult had been diagnosed during childhood. And that's, I think, quite important. And some studies have found actually that for example, that there is a recall bias in adults with ADHD, and it's easier for people that have been received the previous diagnosis of ADHD in childhood minimize the symptoms, while people can overestimate the symptoms if they haven't been actually diagnosed during childhood, and if there is no much evidence of an actual diagnosis in childhood. So I think that's quite important to understand that. I would like to have to know what's the opinion, for example, from Steve or Sandra about that.
Yeah, well, this is an extremely important point. As Franco mentioned, there were a number of studies that came out, some asserting quite strongly that adult ADHD was a totally separate entity from childhood ADHD. That this one study from New Zealand said all childhood ADHD remitted in adulthood, and then all cases of adults with ADHD were de novo ADHD.
They're very smart. They're very smart down there in New Zealand.
Yeah, they're very smart down in New Zealand. Well, I was wondering what was happening in New Zealand, because it's something we hadn't really observed in the studies that we've done in the United States and in Europe. And then some studies from Europe came out that had similar findings, but were a little bit different. I reviewed those studies, actually wrote an editorial for JAMA Psychiatry on the topic, because it was so concerning to me, in part because I think that the studies were, I'd like to say, unintentionally misleading and perhaps dangerous for clinicians who might begin to think that anybody coming in, any adult coming in, saying they just had a bout of ADHD symptoms and needed treatment was somebody who really had ADHD. Now, the reasons why I think the studies were unintentionally misleading are fairly complex. One of them has to do with something called the false positive paradox in epidemiology. It's very easy for the population studies, and these are all population epidemiology studies. It's very easy for these studies to overestimate the prevalence of disorders based upon even a false positive rate of diagnosis. So I suspect that some of the so-called adult onsets were simply false positive diagnoses. The other problem with these studies is that many of the people they called adult onset actually had evidence of having some ADHD-like symptoms or impairments or comorbidities as children. For example, in the first study from New Zealand, where these were so-called de novo adult onsets, 31% of these adults had conduct disorder as children. And so these weren't de novo from the point of view of not having any kind of neurodevelopmental condition. I think the big mistake from the series of studies is they've turned the real question on its head. And the real question is, what about subthreshold ADHD in childhood? It's well known to clinicians that some kids come in with neurodevelopmental condition that doesn't meet criteria for any disorder, but it's causing them problems. And I suspect that this subthreshold ADHD is something that morphs into adult onset ADHD in the future. I'll say one more thing before I give up the floor, and that is that this whole concept of the other thing that was missed in the adult onset dialogue is that we know from all sorts of studies now, particularly genetic studies are very strong, that it's very reasonable to think of ADHD as a trait that varies in the population. Just much like hypercholesteremia, if you have too much cholesterol in your blood, you have hypercholesteremia, but everybody has some cholesterol level. We've seen from many, many studies that there is naturally varying traits of ADHD in the population that is driven by the same genetic architecture of ADHD that we see in patients. What I suspect is that people who are at the threshold of diagnosis in childhood and adolescence are those that are becoming the adult onset cases. The message for clinicians is that you should not expect that someone coming in with de novo adult onset ADHD really has ADHD. these folks really need to be investigated very carefully in terms of what was happening in their childhood. And if you look hard enough, you will find something. If you don't, proceed carefully, because somebody who has ADHD symptoms and is impaired, and where that can't be explained by comorbidity, they need some kind of treatment. But I do say proceed with caution in such cases.
And may I
also
also
ask a question? Sorry.
Yes.
No, go ahead. I'll comment that later.
Okay, I have a question for Steve, because the whole discussion on late onset ADHD is also focusing on the different genetic background of both types of onsets, early versus late onset. And I had understood that the adult onset ADHD had a different genetic background for later onset. What's your comment to that?
Well, that was based on the New Zealand study, doing a study where they looked at genome-wide association data from a very big study of kids, and said that those polygenic scores did not, if you will, correlate with the adult onset diagnosis that they had in the New Zealand study. The main problem with that analysis was that there were only, and people forget this because the New Zealand study is a huge population study, there were only 31 cases of adult onset ADHD. It was actually a very tiny study of adult onset ADHD. My other comment is that there are now, the family studies that were done in the early 1990s that I was part of, we frequently found adult ADHD in the parents of ADHD kids. And when we've studied adults with ADHD, we find childhood ADHD in their children. So we do know that ADHD runs in families. This has been replicated many times, which of course could be familial and not genetic. The twin study literature on adult ADHD is mixed and is fraught with this problem of reports that I think Nicoletta brought up before, that you get different results from self-reports and parent reports. But the best twin study perhaps is the one that came from Sweden, which shows high heritability of ADHD throughout the lifespan, or at least into young adulthood, if you take into account who's doing the ratings of ADHD.
Thank you so much for this comment. Another point you mentioned is how many symptoms did those late onset people actually have in childhood, and these data haven't been published as far as I know. But Louise Roth has shown us in Berlin last year that there are all kinds of different patterns of development of symptoms of ADHD over time. And because these were longitudinal studies, it's very interesting to see whether your hypothesis is true, that many patients who are called so-called late onset people might have actually had subthreshold ADHD in childhood. And I think this is one part of the explanation, but maybe not all, because the group of adult onset was about 90% in adulthood. So that's very, very intriguing, I think.
It's very intriguing. It doesn't correspond at all to clinical practice. And I always emphasize these studies are about ADHD symptoms occurring in population studies. And they don't seem to be as relevant to what we see in the clinical setting, because in the clinical setting, most adults who come in with ADHD have a documented history of the disorder in childhood.
Right. And I think that the point about there being recall bias is really relevant when talking about the difference between clinical populations and epidemiologic populations, because there's no reason for somebody who was asked a series of questions, not specifically about ADHD, to recall that their ADHD symptoms were actually present in childhood when they were not. But if somebody is presenting for evaluation because they have specific concerns about their inability to pay attention,
right,
they are much more likely, I think, to report that these symptoms were in fact present when they were younger. And it's not clear why the recall bias would exist, but I think, I mean, it makes sense that if you're in a setting in which you're seeking help for a given problem, when somebody asks you a question, did you have this as a child, that you would say yes to that.
Yes.
I mean, it's fraught across mood disorders and anxiety disorders also. People who come in depressed tend to report that they were depressed their whole lives, and people who were well tend to report that they were not depressed earlier. So Samuele, do you have a comment about that?
I do agree with this. Actually, to go on this topic, one of my concerns when I first read these papers on adult onset was that possibly authors did not take into account all the possible differential diagnoses, particularly some kind of differential diagnosis, neurological one, sleep disorder, breathing, for example, sleep apnea, which are frequently associated with symptoms of inattention, procrastination, and so on and so forth. So clearly they tried to control for possible differential diagnosis, but I'm not sure that the design of the study and the data set allowed them to control for all possible differential diagnoses. So I think that the key message that Steve highlighted, so to be cautious in the clinical practice, is a really important one. And I personally think that we need more evidence from different types of studies, not only population study, to better address this issue, which, if it's true, it will be extremely important, of course.
Steve, do you have a comment about that?
No, I agree 100% with what Samuele said, that the issues of potential other disorders causing the parent-adult onsets could be a problem. I think the Brazilian study dealt with that best. They did look at comorbidities. I don't know that they looked at sleep issues or, for example, traumatic brain injury as causing secondary ADHD and so forth.
Yeah, I mean, this is it's part of my role to be at least a little bit provocative in discussion. So
go for it.
You know, no. So I think so. This is an important question: the comorbidity issue in adults. I think, and is it the case? Does the panel think it's the case that with children there are a fewer number of likely comorbidities that could be resulting in symptoms that appear to be due to ADHD. For instance, I mean, you know, there are traumatized kids and kids who grow up in stressful social situations who have behavioral problems in school, or there are a lot of different reasons that kids would have it. But it seems to me that there are more reasons that adults would have. There are more possible comorbidities as people get older. So even mood disorder comorbidities, anxiety disorder comorbidities, along with neurocognitive disorders, medical problems. I mean, does that have an impact on the diagnosis, and if so, what? Anybody's welcome to answer.
It could be, of course, because adults indeed have had more time to develop all kinds of comorbidities that should be differentiated from the diagnosis of ADHD. But the numbers in childhood and adults are similar for the number of comorbid conditions, and the percentage is more or less the same. So I believe in children it's 67%, and in adults it's 75% that has at least one comorbidity, psychiatric comorbidity. And in my department, the mean number of disorders is 3 in each patient. So it's quite common to have comorbidities during the lifetime, I would say.
Okay, and then to move on to the more provocative part, even if it's the case that people have comorbidities, if you're applying pharmacologic treatments, that is especially stimulant-based treatments, doesn't matter whether the diagnosis is, whether or not the symptoms are due specifically to the ADHD core diagnosis, or whether it's due to the comorbidity. In other words, if won't stimulants improve some of these symptoms regardless of what the underlying diagnosis is?
Steve.
I'll go first, Sandra, then you. Yeah, I think, well, I suppose stimulants will certainly improve ADHD symptoms occurring in a comorbid context, but I guess the quick and dirty treatment algorithm for people with 2 disorders is you treat the disorder that's worse, that's causing the most impairment, and then you see what's left, and then you treat that. So if someone comes in with a screaming bipolar disorder, you're not going to put them on a stimulant, obviously, even if you think they have ADHD. You're going to treat the bipolar disorder, and then some studies have shown that after you treat the bipolar disorder, you can treat safely with stimulants, carefully but safely, and help the underlying ADHD. I think as a general rule, we've ejected the concept that disorders. One disorder is secondary to another, which was very popular in the DSM-2 and then even in the DSM-3. This idea of a hierarchy of diagnoses, and are moving towards the idea that all disorders, or to some degree, share some underlying etiology and comorbidity, and we want to essentially treat all disorders that are present, but in an appropriate and safe order. Sandra, you were going to talk.
Yeah, I completely agree with having a priority or a severity index, which disorder is most severe and should be treated first. This is also a clinical guideline. The advice to check for symptoms, whether they disappear when somebody is depressed and you start with stimulant. I personally don't like to even try, because I'm afraid that stimulants might be good to reduce the severity of depression in a patient that should be treated with an SSRI, for instance. And I don't want them to increase the dosage because of their severity of their depression with using the stimulant. So I first want the depression or bipolar disorder or addiction to be in remission before we safely can start a stimulant for ADHD as well. So this is based on 20 years of clinical experience and what I advise to my pupils every day. Do you agree?
Yes, well said, Sandra.
And what do you think about the usage, for example, of non-stimulants such as atomoxetine in the case of psychotic disorders like, for example, bipolar, rather than using stimulants?
I think you should treat every patient with the best treatment available. That means that we don't go back to atomoxetine because somebody is bipolar to start with. So I would advise to treat bipolar disorder appropriately first, and then check whether you can add a stimulant or not. And you should stay with the patient, of course, to monitor that carefully. But if you say we give atomoxetine, you withhold quite some effect size from that particular patient. Mm-hmm. That's what I understand the issue, and I understand that we want to be safe with the patient, but we should protect him properly and stay with him when we try. And obviously, we need more studies on that particular clinical issue.
And there is a small evidence base that supports what Sandra said, that it is safe to treat patients with bipolar disorder who have ADHD with stimulants. But cautiously.
I just had another condition which is related to the efficacy of stimulants when they are comorbid condition is the association between ADHD and autism spectrum disorder, which is quite frequent in the clinical practice of child psychiatrists, but also in adults. And in this case, clinical practice clearly shows, and this is also supported by empirical evidence, that stimulants are efficacious, but the effect size tends to be lower. In other cases, we rarely see the dramatic and spectacular effect that we see in children who have just ADHD. So in this case, I think it's important to be aware that it's still worthy, of course, to use psychostimulants for this particular population, but the efficacy is less impressive, and the acceptability and the tolerability is also different. And I don't know, maybe Nicoletta, you may want to comment because you're specifically interested on ASD and ADHD.
Yes, it's. I absolutely agree. I think that regardless of the alternative diagnosis, once all the specific interventions for one disorder are in place, it is important to treat the ADHD symptoms according to the specific rules. So one rule of thumb, like in the clinics, might be to pot, for example, in a population of more sensitive children, like children with autism, that might potentially have less tolerability, would be to possibly starting lower and slower. But then once we have ascertained that the profile of side effects is pretty much similar to like another child that only has ADHD, you can just proceed pretty much like as you would do in a child that only has ADHD, for example. So going at the same speed and the same dosages as other children. So that would be pretty much the typical advice. And
how much weight of the evidence supports the use of non-stimulant treatments at this point? So it sounds like the stimulants have a much larger effect size across both children and adults than drugs like atomoxetine.
Yeah, that's very true. That's very true. The atomoxetine on the one hand, the alpha-2 agonists on the other hand, both non-stimulants, their effect size is about 2/3 or less than stimulants as a rough measure, and that's been fairly consistent. That doesn't mean that some people don't do very well on a non-stimulant. It's something that gets lost in the effect size measure, which is it's an average across everybody.
And so, right. And so where do you think that comes from? I mean, I think part of it may be, I mean, in children, it's harder to, I think perhaps to have sort of an ascertainment bias problem. That is, that people can figure out which treatment they're assigned to. I think with kids, although it's still obviously possible, but certainly in adults may be able to tell the difference between whether they're getting a stimulant treatment or a placebo more than they might be able to tell that they're getting atomoxetine compared to placebo, and that knowing that which group they're assigned to may have an impact. Even with, do you think that has any role in having this differential effect size between stimulants and these non-stimulant treatments, or do you think the stimulant treatments are actually better?
Actually, I would think that that the effect would be the reverse, that knowledge that you were having the treatment would increase the expectation of benefit,
yes,
which would actually magnify the drug versus placebo effect.
No, that's what I'm saying, and I think, and I'm
just saying, okay.
No, I may have said it wrong, but the question is there more of an unblinding effect of stimulants compared to the non-stimulant treatments, and does that explain why the stimulants have a larger effect size? In other words, is it possible that people can tell more readily that they're receiving a stimulant medication because of the side effects than a non-stimulant?
Good question. Yeah, it's a good question. I mean, my gut reaction would be yes, because the effect of stimulants is felt very quickly. On day one, you feel something different.
Right.
The clinical effect kicks in within a week or so, mildly and then strongly in the next few weeks. On the other hand, atomoxetine, some people feel nauseous, and the side effects are pretty prominent. What do you think, Sandra, in that question?
Yeah, I would say once people know that your heart rate increases using stimulants always, I have never seen anybody who was an exception to that rule. There is no blind study at all. Yeah. So when we say that, we could start all over again with all the research, but still there is so much clinical evidence and experience that's very similar and reassuring in children and adults, that I don't think that's the truth either. But you could argue that we need studies with active placebo that some side effects that are evident from the stimulants or from atomoxetine. And I would certainly like to see those studies happening, although it will be hard to find something that's really doing that what you want and not other stuff.
Right. You want that, doing that, and also that doesn't actually have a clinical benefit, right? So if you use caffeine as an
or have other side effects that you don't want to see.
Right, because caffeine we know improves attention, and so it would be hard to use that, for instance.
Right.
And nicotine.
Oh, and nicotine.
Yeah, we'll have them smoking for coffee.
Jerry Rosenbaum, my old chair at Mass General, said that ever since he stopped smoking, he's become a much worse psychiatrist because he can't pay as much attention to his psychiatry.
It
sounds like Jerry.
Yeah, the Jerry thing to say. But the nicotine really helped him.
May I just may I just come back to the question, are stimulants better than non-stimulants? Which in general at the group level is true, but coming back also to the main topic of our review, which was the evidence base, I think that what the evidence base does not tell us right now is what medication works better for whom. We see in the clinical practice that some patients respond better to specific type of medication. And meta-analysis don't tell us this because they are at the group level. What probably may help in the future is the implementation of the so-called individual data patient meta-analysis, where we aggregate and we pull together large data sets, and we have access to the individual data patient. But this will require really a change in mindsets and an effort from the international community to share, to retrospectively and prospectively share data, which will be a large effort, but probably worthy. I don't know if you, Sandra, Steve, or others have any comment on that.
Yeah, I think it's a great idea to collect more data, to have huge samples, big data, because I think we will learn new, we'll have new conclusions based on those data that we can never achieve studying small samples as we did in the recent past. For instance, we try now to use the Kooij test, the CBT test, also measuring hyperactivity before and after each medical treatment in our department. And we have now data of 1,000 patients that we are still trying to analyze. And we will find differential effects of different medications on the domains of ADHD, such as impulsivity, hyperactivity, and inattention that test measures objectively. So behavioral symptoms, but nevertheless, we can learn something of it about how it works in certain groups of patients, and we can maybe identify which patients need what in the future. So heading for more personalized medicine.
Well, it would certainly be helpful to have longitudinal measures of response to treatments for ADHD that would be easy for patients and families and clinicians to use, wouldn't it?
Absolutely. Can I also go back to the discussion about the adult onset ADHD, or rather how to diagnose, and whether we are really catching, like everyone who clearly has impairing symptoms, and actually the implication of it in our in this current work. So if that is true, and considering the DSM-5 came out relatively recently, like most of the evidence we've been looking at would be based on a selection of patients with ADHD that were only the ones that were the most impaired, and possibly we would have missed all those participants that would not reach the cutoffs, like of the 6 symptoms of inattention and hyperactivity and impulsivity that were required for the DSM-4. So we would be missing already a number of patients that nowadays will be diagnosed with ADHD.
Yes.
So some of the evidence that we're looking at might not be fully up to date, if you know what I mean. Like we might not know what happens, if adding those sub-threshold, let's say, patients would add any more, increase the effect sizes, or give us any different results.
Samuele,
Yeah. Sorry.
Or Franco, do you have a quick comment to wrap us up?
No, I just think that I totally agree what Nicoletta said, and also actually we've seen such a big amount of research really recently coming out, and we might expect to have much more developments in the next future, I think.
That's great. Well, our hour went by very quickly. I wanted to thank everyone for joining us on this EBMH Google Hangout. The authors of the systematic review and meta-analysis, Franco di Crescenzo, Samuele, Cortese, and Nicoletta Adamo, and our terrific discussants, Sandra, Kooij, and Steve Ferrone. on behalf of Andrea Cipriani, the editor of Evidence-Based Mental Health, and our two terrific support people, Veronica Heaney behind the scenes and Roxanne Kinajad helped organize this. I'd like to thank you all for joining us. If you'd like to watch this, it's archived on YouTube, and please follow us on Twitter at EB Mental Health. Thank you very much for joining, and we'll sign out for now.